All right, so the first case example that we'll talk about is what I'll just classify as a simple case. And it's Miss Betty that we have here. And she came into the office, for two reasons. One, she had the lower crowding that kind of bothered her a little bit. But her dentist pointed out the fact that she's hitting on that tooth and it's starting to cause a little recession on it. And so she didn't like, the crowding and the malalignment, but I think she would have lived with it, but she did want to save the tooth. And, the doctor or her dentist did a great job of explaining to her the importance of, having a functional bite. So it was the crowding and the recession that was starting to form around that lower left one that really brought her in. But you can see, just a mild crowding up top, moderate crowding on the lower. She has that traumatic occlusion on that incisor down in the bottom. And the associated recession that came with it. She's missing the lower right 6, and so that upper right 6 has started to supra-erupt a little bit. She doesn't have any plans or any immediate plans to restore that missing lower right 6. But I tell patients all the time, like, listen, we're going to put it where it needs to be. And if you decide that you want to do something later on, you will have enough clearance and enough room to do so. And then also, I just didn't like the constriction of her lower arch. And so I'm not overly concerned with the posterior part, but mainly just the lower 2 to 2 is extremely V-shaped. And so I just want to round it out, not a ton of expansion because I don't want to, expand too much, especially in the intercanine area. But I did want to round it out a little bit to get it away from that nice V-shaped arch that she has now. So the treatment plan is non-extraction. We're going to line the upper and lower teeth, do some IPR in the lower to help tuck that incisor back in and get some positive overjet on that tooth. But then also intrude the upper right 6 and 5 to give her some clearance. So that's the game plan that we have. For Ms. Betty. This is her radiographs, nothing too dramatic. Again, we're missing multiple teeth in the upper left quadrant. All wisdom teeth are taken out. We're missing that lower right 6, and you can just see how that upper right 6 is starting to super erupt into that missing space. Okay, so here's her setup. And this is just the typical setup. Again, you can see my attachments. For her, we didn't have a ton of bite opening to do. And whenever I have missing teeth, I try not to put too many attachments on, just so that, we don't lock the aligners in when we do it. So for her, just put it on the lower left 6, the lower right 4, and then this lower incisor that we're trying to correct. And so, one of the things that I want to point out, and this is kind of the staging that I'm referring to, is creating space before it. And so if you look here, when I get to number 10 right here, I didn't move that incisor until that. So I created the space first. And let me just go back to that because I think I didn't show it as well. So again, if you look when I get to 10, that's where I had created space and then I started moving it. And so that is the biggest part about the stage and being able to set that up and, not move teeth until you have enough clearance for it. Okay. So that's what I wanted to show. And then in the upper arch, there's not a ton of work that needs to be done. So we're just going to, line everything up. She does have some crowding, especially with the upper 2 to 2. So we just kind of want to line things up, get everything nice and pretty. But the biggest thing is, or the majority of the work is in the lower arch for us. So this is the initial setup that we have for Betty, and we're ready to go. And we have 16 in the upper, 16 in the lower, which is not a lot of aligners. And again, this is just a setup, and this is my typical attachment protocol that I'll do. And this is just kind of highlighting the space that was created. So this was at aligner 10, and again, you can just see mesial and distal to that incisor, we had space created first. So up until stage 10, that tooth had not moved. And then after 10, that's when we tucked it in and aligned it with the rest of the teeth. So this is where she finished after that initial round of upper and lower 16. You can see that upper right 6 and 5 have intruded, which is nice. We got some good alignment in the upper arch, in the lower arch as well. The lower left one is still, the mesial is rotated out just a little bit more than I would like it to be. And had that been tucked in, we probably would have been done. And so I wanted to get it, just lined up just a little bit more. And you can see we got rid of that traumatic occlusion between that lower incisor. And you can already see just with that in that short period of time that the gingival zenith on all the lower front teeth are about the same now, whereas before we were having a little bit more on that lower left one. And again, I'm not saying we grew bone or grew gingiva. It took away the trauma that was happening to that tooth. And so this is the refinement setup that I wanted to go in, and here you can appreciate how we just needed to align that a little bit more, and then being able to bring it in and tuck it in to kind of round it off a little bit more was also a good idea. And I just wanted to get a little more intrusion on that tooth. I did go back in at the end and kind of just smooth out those incisal edges because sometimes, we all know that when they're worn, it's kind of hard to know where to adjust and where not to. But I typically will take the most rough edge and extrude it a little bit past that so that I can smooth that off and make it match up with the rest of the teeth. And so this was her refinement setup, just 7 in the upper, 7 in the lower, just to kind of do that little fine tweaking. And this is where she finished. And so again, we got nice intrusion of that upper right 6. We got rid of that traumatic occlusion in anterior, didn't overly expand the anterior portion, the 3-3 canine width, but we were able just to round it off and get that lower crowding alleviated rather nicely. We did do some IPR with the first round. I forgot to mention that to tuck it in a little bit. And then I think I just hit it with a little hand strip. So just pretty much just to polish off the contacts, not any real IPR for the second round to bring it on in. And then these are the final sets and the final pan. And this is just a before and after. Again, you can appreciate the lower alignment that we were able to do from Miss Betty, but then also the before and after set to show the intrusion. Now, again, this wasn't a severely super erupted tooth, so we didn't have to, intrude it 4 or 5 millimeters. I mean, we just needed to get a little bit just to kind of raise it up a little bit. And then this is her case summary. The first set again was 16 upper and lower aligners. We use Zendora Flex 10-day changes, which is my standard. A lot of times in the refinement, I'll do 7 days, but typically for the first round is always 10, and then I'll adjust it accordingly depending on what movements I need to do in refinement. But the refinement, we needed 7. That 2 was Zendora Flex with 10-day changes. Total treatment time was 8 months. And so this was a very efficient treatment. I think we saw her 4 times, which was to, deliver the attachments the first time. When she came back, we had to do the scan, but then she had to come back to get the next set of aligners. So she was not in our office that often. And then the overall treatment time was very applicable as well. So a great turnout. She was thrilled with it. Her dentist was excited that she was no longer having that traumatic occlusion in the front. So this is just a run-of-the-mill case. And even if you decide that you don't want to kind of go into the deep end with a lot of these comprehensive cases, doing some of these routine cases like this will save you a lot of time and money, and you can get the results that you're looking for.